We are very pleased to welcome Dr. Samir Sinha. Dr. Sinha is probably no stranger to most of you, but just a quick reminder of some of his accomplishments. He serves as the Peter and Sheila Godsoe Chair in Geriatrics and is the Director of Geriatrics at Sinai Health System and the University Health Network Toronto. He is also the provincial lead for the Ontario Senior Strategy and an associate professor of medicine for the University of Toronto, an assistant professor of medicine at Johns Hopkins University School of Medicine. He's also Canadian InterRAI Fellow, and amongst other things. So before we get started, I'd like to let you know how to engage with Dr. Sinha today. Please type any questions you have at any time in the chat box, and we'll have a question period at the end of the presentation. And I'll start by answering the most commonly asked question. Can we have a copy of the slides or recording for this webinar? And the answer is yes, you can. We'll have them posted on our website and available for you after the presentation. And with that, I'd like to invite Dr. Sinha to take the stage.
Thank you very much, Wendy. Can you hear me okay?
We can hear you, Dr. Sinha.
Perfect. Okay, so I'm going to see if I can try and share the slides. It says that I can't, so I don't know if you would like to share them.
Okay, we'll just get that going in the background. Just one second.
Sounds good. Perfect. Okay, and I believe I'm going to see if I can. Okay.
You may be able to steal the screen from us and click ahead. And if that doesn't work, just let us know when to advance the slides.
Okay. I think I can't. I'm not able to advance them on my end here. Sometimes I can, but okay. How about we? I'll get you to click for me if that's okay, and we'll go from there. Okay. 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 Let's. So thank you very much, everyone. It's great to be here today. Oh, just want to say thank you again to the Regional Geriatric Program of Toronto for inviting me to help deliver this webinar. And this really came out of a conversation with a number of folks who are now seeing that there is this thing called InterRAI home care assessments that are now available to many of the clinicians working in specialized geriatric services via Connecting Ontario. And so really the goal of today's presentation is just to kind of demystify that and give folks some practical tips on how to move forward. So I'm going to ask the slide be advanced for me. Okay, so our presentation objectives for today are really to understand the principles of effective client assessments in providing home care, understand the role of the InterRAI contact assessment and the InterRAI home care assessment in the delivery of home care in Ontario. We'll learn where to find InterRAI assessments in the Connecting Ontario Patient Information Portal, and then we'll also be able to gain some insights on how to navigate and interpret the information presented in the InterRAI contact assessment and home care forms in a way that can support the care you provide to your older patients. Okay, next slide, please. So in this slide here, this is just a slide that I've borrowed from the Ministry of Health and Long-Term Care, which really tries to help outline kind of what are some of the principles of effective and efficient client assessments. And I won't go through all these points in detail, but really it really focuses on these 4 overall aims, really about using standardized assessments as a way to promote efficiency, quality, safety, and customer service, because often we think about assessments as a way to kind of determine how much home care someone gets. But again, there's many different aspects about using standardized assessments in a way that can support a number of different aims as well. We'll advance the next slide. So in terms of understanding Ontario's model for assessment of client needs, really the best way to think about this is in 3 broad buckets. One is that there's actually legislation, regulation, and policy that really speaks to the importance of actually legislating and putting regulations in place to ensure that we have a standardized way to actually think about home and community care assessments or client assessment in a number of different settings. And so when we think about how we deliver services at the level of our LHINs right now, LHINs have adopted what we call the client care model to assist with this idea of triaging, assessing, and providing care management for clients in home and community care. So typically, these assessments are done by a care coordinator, through the LHIN, which is usually a nurse, but not always. And then the LHIN will share these client assessment results through something called CRIS, which is the Client Health Record Information System that was developed by the former CCACs and is now managed by the LHINs. And this is their own electronic health record that crosses Ontario as well. And so when we think about the use of InterRAI assessment tools, this is what the ministry has been supporting for a number of years to help deploy the use of consistent assessments, and then supporting this by using a common technology platform, which is in this case the CRIS system. And so you can see that all 14 LHINs, all long-term care homes in Ontario, and many community support services, support service agencies and mental health and addiction agencies are using InterRAI-based decision support tools to deliver community care. And in terms of when you think about the work that the LHINs do, the most commonly used tools that we'll focus on are those of the InterRAI contact assessment and the InterRAI home care. But you'll also understand that there are other tools out there like the InterRAI long-term care form, the InterRAI palliative care form, and that's where those different settings will use those, including the community health assessment, which is the commonly used tool used by our CSS agencies. We'll go to the next slide. So when you think about what are InterRAI assessments, because I mentioned it a few times now, this is where it's important to understand what is InterRAI. And InterRAI is actually an international collaborative network of researchers across 32 countries. As Wendy was mentioning at the beginning, I'm actually a fellow with InterRAI and one of the Canadian fellows. And InterRAI has developed these internationally standardized client assessment tools with a focus on older persons, persons with disabilities, and those affected by mental illness. So these InterRAI, so home care in Ontario has been using the InterRAI suite of assessment tools since 2002, so almost 20 years now, to basically support evidence-informed care in the community. And these tools not only provide decision support, but they also use algorithms and client outcome measures. These are the results that come out of these assessments, such as the popular Canadian-based tool called MAPLE. We'll talk a little bit more about that in a bit. And basically, whenever you fill out an InterRAI assessment, these are all assessments that are using software. So these aren't paper-based tools. These are actually tools where you're actually clicking in to assessment. You're filling out a computerized assessment, which then is supported by software, which uses algorithms and the use of analytics, including predictive analytics, to help predict client need for things like long-term care placement, risk of hospital readmission, but also a whole bunch of other outcomes and other activities as well. So as I mentioned before, the typical things that are used by the LHIN home care are the InterRAI contact assessment and what we call the InterRAI home care. CSS agencies across Ontario are using the InterRAI, what we call preliminary screener, and the community health assessment. LHINs are also using the InterRAI palliative care assessment as well. And the goal is that the InterRAI assessment tools collect standardized information about clients to make evidence-informed service allocation decisions for home and community care. And this is really around these domains of physical ability, medical complexity, cognitive ability, mental health, social determinants of health, and caregiver distress. Things that we're often commonly interested in understanding when we're thinking about the needs of an older person. We'll go to the next slide. So in terms of some facts about InterRAI assessments, and I'm going to be annoying to my clicker here, but we'll just go ahead and click away. So first of all, InterRAI assessment tools are designed to collect the minimum data required to help with useful decision making for users of them, while minimizing the documentation burden and completing administrative requirements. So for example, the common example I like to use is that some people will complete a Morse-Falls assessment, and that's a tool that asks a number of questions, but InterRAI researchers over time have helped to determine that simply asking the question, have you fallen one or more times in the last 90 days, is as sensitive and specific as asking a full Morse-Falls assessment. So that's why InterRAI researchers over time have basically worked to try and say, what is the minimum amount of data that we need to basically get us an answer that can help us in care planning? So that's what we mean by minimum data. We'll go to the next point. So the data elements in each tool are also standardized and identical to support sharing across sectors and minimize duplication of efforts. So we'll see a slide in a few moments that basically shows that when you think about home and community care, actually there are a number of different assessment tools that actually are all using the same data elements, and actually then can derive a lot of the same things, but they're all right-sized according to the care that one would actually be providing. So again, when we ask about have you had one or more falls in the last 90 days, those questions are standardized across all InterRAI assessments to make sure that you could share that data with time, especially as people navigate the system. Countries around the world have implemented the use of InterRAI instruments. And when you think about the home care instrument, for example, countries like Finland, Belgium, New Zealand, and 29 states across the US, for example, many countries around the world have implemented the home care system, including all provinces and territories in Canada other than Quebec. And by doing that, it allows us to actually not only compare our data with other people across the province, but across the country and internationally as well. And all of these tools are made available free of charge. And right now, the Canadian Institutes for Health Information supports the mandated universal adoption of the InterRAI assessments across Canada. And so currently, CIHI stores 12 million InterRAI assessment records on over 3 million Canadians. So any of you are interested in research or quality improvement, this is a freely available resource of de-identified data that allows InterRAI researchers and others to actually understand more about what we're doing, and allows us to even develop even more refined tools with time. Go to the next slide. Thank you. So when you think about this, most people think about just doing an assessment. And for most of us as clinicians, we just think about using an assessment to come up with a care plan. But you can see that InterRAI assessments are designed so that they can help with things like resource allocation. They can help determine outcome measures and quality indicators in a number of different ways. And so that's why we talk about the idea of one assessment, multiple applications. And in some cases, clinicians may not really care so much about resource allocation, but their managers do. And hospitals or organizations that are thinking about the quality of care that they're providing, again, these are assessment systems that can generate all of these things, and are often used by different providers. Go to the next slide. So when we actually think about first generation assessments, for most of us who are clinicians, we're used to doing this, where we basically say, I need a falls risk tool, I need an MMSE, I want to do a nutrition screen, ADL screen, CAM, and what we tend to do is when we're making up an assessment, we kind of piece together a whole bunch of different things together, and make a really, really long form for us to click out. The challenge is that sometimes you ask similar questions for each of the different scales, as opposed to, so you might be asking about falls in a few different ways, or you might be asking about cognition in a few different ways. And so often there's almost a duplicate of time and almost sometimes a duplicate of question when you think about traditional first generation assessments. We'll go to the next slide. This next slide helps to kind of understand what we mean by second generation assessments, and we'll keep clicking through here. What we see here, that's perfect, thank you. What we see here, this is what we call a second generation assessment system. And this is where you look at what an InterRAI assessment does is it basically has the assessor basically ask questions or score an assessment making observations. But those observations then, using those algorithms and that computerized software, can then generate what the yellow arrows are pointing to, such as diagnostic screeners and risk assessments, scales and severity measures, clinical assessment protocols, quality indicators, and case mix tools. So as far as we're concerned as clinicians, or as far as I'm concerned as a clinician, I'm just basically doing the assessment, which makes observations in these various domains on the left. But the value of doing those observations is then all these other outputs can be generated using evidence-based and evidence-informed algorithms. So we'll go to the next slide. So when we start thinking about, and go ahead. So when you start looking at home care assessment trends in Ontario right now, we see that the first point is that client acuity is a strong indicator for whether an assessment is conducted and the decision is used at a specific assessment tool. So typically, for example, in Ontario, the InterRAI Home Care, which is a longer tool, is reserved for more medically and socially complex clients. And these are the typical clients in the community who might be cognitively impaired, require assistance with their activities of daily living, might be clinically unstable or at risk of functional decline, and need care over a long period of time. So the majority of clients who are receiving home care in Ontario are actually receive a much shorter instrument called the InterRAI Contact Assessment. And most of these clients are actually just assessed over the phone. So they're just asked a series of questions, and then that is able to help determine whether they'll need a higher level of assessment and a more in-depth level assessment. And generally, those who actually have a higher assessment urgency have shorter median wait times to get assessed with the InterRAI Home Care. So again, this is kind of giving you a flavor that the way we develop the system in Ontario is designed to make sure that complex clients with complex and high needs wait less for those assessments to determine their care needs. We'll go to the next point. So again, we also know that through the consultations that the ministry's been doing, we know that there are opportunities to improve information sharing to integrate assessment data with provider partners. And that's why expanded access to the client health and information system that the LHINs operate, Connecting Ontario. These are all assets that can be used to make improvements, to make assessments conducted by the LHINs valuable for direct care providers and help with the sharing of that information to help others in their assessments as well. So we'll go to the next slide. So when you actually try and look at where you can find an InterRAI home care assessment, for example, so unless you have access to the client health record information system called CRIS, if you're a LHIN care provider, or you might be working through the LHIN in that way, or if you're a community support services provider, our community support services agencies, the 600 or so agencies, are using another ministry-built tool called the Integrated Assessment Record. But most specialized geriatric services providers like myself, where my office is based at Mount Sinai Hospital, I have access to Connecting Ontario through my electronic health record at the hospital. And this is actually the mechanism through which I'm now available as a clinician to view InterRAI contact assessments and home care assessments. And so, for example, if you go into Connecting Ontario for one of your older clients, whether you know they're receiving home care or not, when you go into Connecting Ontario and you simply, pull up you look at your patient's information, if you look under the document or notes section and you look back over a period of time, you can actually see that this patient, for example, has had some geriatric medicine clinic visits, has had an inpatient discharge summary, some inpatient consult notes, but also you'll see this is what it looks like: assessment, InterRAI home care assessment report, one that was done on, it looks like April 29th, and another one that was done on October 9th, for example. So this is an example where this is where you'd find those assessments. Okay, so then if we click through to the next one, so then if you actually get to, if you click onto a contact assessment, for example, what is this? Well, an InterRAI contact assessment is a standardized 40-item assessment organized in the following sections, and it's based on asking the client, for example, questions around what things were like for them in the last 24 hours. So it's a short 10 to 15-minute assessment, and it asks them about some common demographic information, questions around intake and initial history. It does some preliminary screening questions, a clinical evaluation, and a summary. We'll just click the next point. And then what we also see is that InterRAI contact assessments, actually just by asking those questions over 10 minutes, can actually derive 4 algorithmic scores, something called the self-reliance index, another thing called the assessment urgency algorithm, then another one's called the service urgency algorithm, and another one is called the rehab algorithm. So again, that 10 minutes of work just asking some basic questions over the phone can give us some real valuable inputs that can help tell us how urgently this person needs to be seen, and what other services might we prioritize for them. So we'll click through to the next slide. So when you think about InterRAI assessments, again, we'll talk a little bit now about diagnostic screeners and risk assessments, because this is an example of what the InterRAI contact assessment will generate. Again, it's making some observations, but again, a very limited number of observations. But what's really powerful about this is it really helps give our LHIN colleagues, for example, who are assessing a person for some home care, just the quick information they need to know how to plan services, but also to help indicate whether this is a person who might benefit from certain services and other things quicker as well. So we'll go to the next slide, and this is where we'll kind of explain a little bit more about some of those InterRAI contact assessment algorithms. So for example, there are 4 things that I want to feature here. One is what we call the self-reliance index. So what are those 4 things that I mentioned? Well, self-reliance index really is a descriptive indicator that helps to indicate impaired self-reliance in the presence of a single ADL or cognitive impairment. So on those observations, if an individual indicated that they have problems with, for example, dressing below the waist, if they said they had a problem with mobility, or if they indicate they have a cognitive impairment, that tells us that this individual is more self-reliant, for example, on other people. And that actually helps to indicate that they're at higher risk, and probably need a little bit more support. The assessment urgency algorithm incorporates the self-reliance index, for example, and it's used to help prioritize the need and urgency for comprehensive and follow-up assessments, like the InterRAI home care. So some of you who are familiar with another InterRAI-based tool called the ED Screener know that that's a simple tool that you can use over the phone. It takes 48 seconds to do through an iPhone app, for example, and it can prioritize people on a score of 1 to 6 and really help tell you if they're a 5 or a 6, then they really are in urgent need of care and services. If they're a 1 and 2, they probably could just get usual care, and probably don't need to have an InterRAI home care assessment. The service urgency algorithm is used to identify persons who may be in urgent need of services, such as wound care and IV medications. And then there's another 4th handy one called the rehab algorithm, which is also useful based on responses that people made in their observations to identify people who may be candidates for rehabilitation services, such as physiotherapy or occupational therapy. Basically, these are just outputs, if you will, that help a care coordinator feel more confident in their decision making as to what services that they might want to allocate, and have some evidence to back up their decision making as well. So we'll go to the next slide. So when we look at the assessment urgency algorithm, for example, I talked about the self-reliance index, so you can see that part there. And this starts getting you to some of the language of InterRAI, because when you start looking at an assessment, you'll see that there are different sections, for example, and there are different questions that are asked here. So the self-reliance index is the thing in the big box at the top, and it basically here says that if the person has problems in one or more of their cognitive skills for daily living, or if they're having challenges with doing one of these 4 ADLs, bathing, doing their personal hygiene, dressing below the waist, or mobility, then that tells us that they have an impairment, with respect to their ability to be self-reliant. And so the assessment urgency algorithm takes that data, and then it also processes it through by asking other questions, such as if there's a problem with doing one's tasks on their own, that they're somewhat self-reliant, and then their family is overwhelmed, if you go down to the right, then that immediately gets you a 6 on the assessment urgency algorithm. So this is a person who might be cognitively or physically impaired. The family caregivers are overwhelmed. Well, this means that we need to probably get in there quickly and do some things to really stabilize that situation. On the other hand, if the person's actually quite self-reliant, they have no problems with any of their core ADLs or their cognition, they rate their health as being really good, and they don't say that they actually have any issues in terms of clinical instability, then they would actually end up being a 1 there. So this kind of shows you how InterRAI uses these algorithms, so that way the data that was collected in a 10-minute period all of a sudden starts giving you these outputs like a self-reliance index, assessment urgency algorithm, without anybody having to do any extra work. So let's go to the next slide. So now when we get to the big assessment that's used in home care, this is actually what we call an InterRAI home care assessment. And this is where I wanted to show you this one in a little bit more detail here. So when we look at an InterRAI home care assessment right now, you can see that there's a lot more sections than what you'd have in a contact assessment. So this is an assessment that a trained assessor, so a LHIN care coordinator, on average should probably take about an hour to complete. So this is not a small assessment. And I think I might have a slide coming up, but I might not, which actually shows that only about 22% of home care clients in Ontario are being assessed with an InterRAI home care assessment. The vast majority, about 80% or so of home care clients in Ontario, just receive the short contact assessment that takes about 10 minutes to do. But for that subset of home care clients who are going to be individuals who might need ongoing longitudinal home and community care and have significant issues that need a more detailed assessment, this is what the InterRAI home care assessment does look at overall. And you can see these are all the sections of the assessment from A to T here, and we're going to go through some of these in particular. So we'll go to the next slide. Okay, so remember how I talked about InterRAI assessments being second-generation assessment systems, and I talked a little bit about diagnostic screeners and risk assessments. Well, another good output of InterRAI assessments are what we call outcome measures, or scales and severity measures, and we'll focus a little bit on this now, talking about this aspect of the output that you really see come to light in an InterRAI home care assessment. So we'll go to the next slide. So in terms of this slide here, when we start thinking about InterRAI outcome measures, we know that many InterRAI outcome scales have been benchmarked for validity with industry gold standard outcome measures. For example, there's a scale called the Cognitive Performance Scale, and there's a newer one called the CPS2, the second generation of the Cognitive Performance Scale. And this has been validated against the MMSE. And they've been shown to be valid. So that if you actually do these, that you're actually, they actually are giving the same output that you would get with an MMSC. They're reliable in terms of, being able to actually reliably and consistently, by no matter who collects that information, get you the same results, if you will. And the responsive, meaning that these outcome measures, are sensitive enough if that there are changes, that these scales will also give different outputs as well. So this allows a single assessment, that home care assessment, to provide a clinician with multiple outcome measures without the need to complete multiple separate outcome scales, for example. So that one assessment that a LHIN care coordinator can do can then come out with a bunch of different outputs, as opposed to having to do an MMSC in addition or other tools in addition to that. And many outcome scales are shared across different community assessments, such as the home care, the community health assessment, the long-term care facilities, and the palliative care assessments. We'll go to the next slide. So this just gives you a sense when you start thinking about all the different outcome scales and severity measures. This just shows you what an InterRAI home care assessment in column in the second column. This shows you all the different outcome scales that can be derived. But I reminded you that the community support service agencies, they use something called the community health assessment, which is a shorter assessment. Long-term care homes in Ontario use their own version of an InterRAI assessment that comes out with a number of similar outputs. And then also the LHINs also are using the palliative care assessment as well. And you can see that many of these different outcome scales and severity measures are calculated in the same way across a number of different instruments, again, where the items are actually the same. Now, when instruments shrink or expand, for example, this is where actually more or less of these outcome scales and severity measures can be collected. But really, if you think about the InterRAI home care assessment, this is where you get pretty much all of these things except for the last one at the end, which is more specific to a long-term care home. So we'll go to the next slide. So the key thing to remember is that the higher the score, the more severe the outcome scale or measure. And the first one I wanted to introduce you to is what we call the CPS, or Cognitive Performance Scale, so you can understand these a little bit better. Go to the next slide. So when you look at the cognitive performance scale, so we're now going to go into this individual's section on cognition here. And what I've done is I've highlighted section C, which is the cognitive section here. And section D is the communication and vision section as well. And so you can see in cognition, we're asking about their ability to make decisions, and saying how, how impaired are their abilities? Are they not impaired to they're actually in a coma, if you will? We ask about short-term memory, which is section 2. We also ask about the potential for delirium. So you see some delirium-like questions in 3 and 4, if you will. And then we also ask about changes in that. And so those latter elements are actually useful and contributory to what we call the delirium risk scale and predicting delirium. And the InterRAI assessments and the delirium risk scale are just as sensitive and specific as the CAM. But in this particular case, I want to focus on the cognitive performance scale, which asks the former questions about memory and recallability, and also a person's ability to make cognitive skills for decision making. But also, it also takes into account their ability to make themselves understood. And so you'll see the coding here is basically asking about how able is this individual in section D able to make other people understand what they're talking about, if you will. It also looks, the communication and vision section also looks at their ability to understand others and also ask questions about hearing and vision. But as far as we're concerned for this particular scale, looking at the cognitive performance scale that's linked to the MMSE, what you see here is it looks at some of the items, questions 1 and 2 in cognition, and questions 1 in communication and vision. We'll go to the next slide. So depending on how things were scored here, you can actually see the algorithm here and understand a little bit about the magic behind these InterRAI assessments. And so you can see here that really, in order to derive a cognitive performance scale, the scores being at the bottom 0 to 6 here, so 0 being intact, 1, 2, 3, 4, 5, and 6, looking at kind of levels of cognitive impairment, if you will. You can see this is where the different items that we were talking about before around decision making and also about impairments in terms of making someone making oneself understood, or even one's short-term memory. All of this together are taken into account in terms of helping to determine where this person is. So, for example, if we go back one slide, if we can, so we'll see that this person, for example, scored 3 in terms of their cognitive skills. So they were determined to be decisions are consistently poor and safe. Supervision is required at all times. It also says that when it comes to short-term memory, that really they're having problems with their short-term memory and their procedural memory. And, they're usually understood. They're not perfectly understood, but they're usually understood with a little bit of time. So when you go forward one slide again, you can see here that you can now start seeing where that person scores on the next slide in terms of the algorithm as well. So this is where you see, again, from that standpoint of decision making, for example, this person basically scores a 3. So they would actually go down to the left in terms of they would be considered to be impaired. And when we think about that impairment, for example, around decision making, we actually see that they would actually score, when you look at their severe impairment count, they already have scored a moderate impairment on the decision-making question of number 3. But this is a person who actually is able to make themselves relatively well understood. So remember that on that question about being understood, they scored only 1. So under that section where it says severe impairment count in the middle, they only count 1 issue, so which is that moderate impairment. So that's how they land at number 3 as a moderate impairment. So it's always a little bit bewildering when you're looking at it for the first time, but I wanted to show you the algorithms behind the scenes here. Otherwise, people think this is voodoo and it doesn't really make too much sense. But actually, there's a lot of hard work and science that have gone in to actually making these things work. But you can say, okay, Dr. Sinha, so you're saying on the CPS scale, your patient scores as being moderately impaired cognitively. Well, but I don't understand that. I'm used to understanding the MMSE, and I know that if I was to do an MMSE, this person might score maybe a 15 out of 30. So how does this rank against the MMSE? Because that's the language that most clinicians know how to speak as well. So we'll go to the next slide. So on the next slide here, again, when you look at the person's scoring, that moderate impairment is basically scored when it's been done head-to-head against the MMSE. Lo and behold, here's what the person, it correlates as a moderate impairment just by answering those few questions with an MMSE score of 15, for example. And again, this is a nice scale, an example where this scale has been validated against the MMSE, and all InterRAI scales have basically been designed so that they are not inferior to, and in fact, in many cases, they're actually better at predicting things like cognitive impairment and ranking that out. So simply by asking these few questions here in questions 1, 2, and section D, questions 1, we were able to save, if you will, the similar amount of time as you would traditionally doing an MMSE if you trust that this is actually just as good as doing an MMSE in that way. So we'll go to the next slide. So in terms of the next one that I wanted to talk about, we'll just make another click. We'll now talk about the depression rating scale. And so when you think about the depression rating scale, this is under section E. This is where we ask questions about mood and behavior. And so this scale identifies a person's likelihood of a new diagnosis of depression within the next 6 months. And it basically is based on looking at their responses to questions E1 and questions A through G. So it's basically asking, are any of these issues present or not? So 0 means they're not present. 1 means that they've been present but not exhibited in the last 3 days. 2 means that they've been exhibited 1 to 2 of the last 3 days, and 3 is that they've been exhibited all the time here. And so again, for each of the input items of the above, based on how they answer those questions, then they're all actually scored using the algorithm. And so the software actually will recode everything. So if there's a 3, it's recorded as a 2. Don't worry too much about that. But the point is here that there's a final scale where those 7 items are depending on how you score 0, 1, or 2, will give you a maximum score of 14. And through the depression rating scale, the DRS, a cutoff score of greater than or equal to 3 has been shown to identify a person at risk of clinical depression. And this is a scale that's been validated against the Cornell scale for depression and dementia, the Calgary Depression Scale, the Hamilton Depression Rating Scale, and again, similar to the Geriatric Depression Scale as well, where that's been seen head-to-head. The reason why this one was really good to look at against tools like the Cornell scale for depression and dementia is remember that about 2/3 of clients who are receiving home and community care in Ontario, and most of the people receiving InterRAI home care assessment are living with dementia. So this is where we actually want to be able to have a depression rating scale that's pretty sensitive and specific for really looking at depression in people with dementia or not, or people who don't have dementia. And so this is why this has been validated against these higher level tools that are really validated in people with dementia as well. We'll go to the next slide. So in terms of the next one that I want to look at is MAPLE, because some of you may have heard about MAPLE levels and heard that, is this client a MAPLE 4 or a MAPLE 5? And so when we look at understanding the method for assigning priority levels, that's what MAPLE stands for. It's a scale that again uses different items to actually help determine a person's priority levels from being low priority all the way up to high priority. And you can see what a level 1 means. A level 1 means that this person they don't really require any services, or they might at most need some light home care services. So they're pretty relatively independent. They don't really have urgent needs. Whereas if you go to number 5, for example, this is where you look at very high. This is an individual, for example, that might require 24-hour supervision. They may need residential support, and they're in community with support, but they would require 24-hour supervision. So basically, in Ontario, this was actually a system or a scale developed for use in Ontario many years ago to help make sure that people who are getting into our long-term care homes were at least a Maple 4 or a Maple 5. And so we set a standard a number of years ago that we want to make sure that over 90% of the clients who are in our long-term care homes in Ontario are Maple 4s or 5s. Because in the past, when we started using the system, we found that if the person's a level 2 or a level 3, they probably could be better supported with community supports. And so it almost prompts us to help think about the person's care a little bit more differently. So without this intervention, individuals with the highest priority level are 9 times more likely to be admitted to a nursing home than are the lowest priority adults. So this helps to understand that if we're screening someone doing a home care assessment and they're Maple 5, it means that we probably want to prioritize putting some supports and care into place because they're at very high risk of ending up into a nursing home compared to, say, those who score at the level 1, if you will, there. And I'm just going to show you this next slide here, because this next slide kind of, again, gives you a little bit of the sense of how these things are derived here. And again, this shows you how it takes different items that are collected during an InterRAI home care assessment, for example, and it really uses an algorithm. So it's kind of a decision tree that takes you down in terms of understanding first, does the person have an ADL impairment or not? And depending on how is their cognition? Let's look at their behavior. Let's look at their issues about wandering, for example. You can start seeing all these different things are all items that are scored in an InterRAI home care assessment. And again, these together can create an algorithm that can help us understand these needs a bit further. We'll go to the next slide here. So the final one I want to show you here in terms of scales and severity measures is one thing called the DIVERT scale that Dr. Andrew Costa at McMaster helped to create. And again, this is a scale that's actually derived again from the InterRAI home care assessment. This was a scale that was developed back in 2015. You'll see the source down below. And again, this was using data from home care assessments in Ontario and in the Winnipeg Regional Health Authority. And you can see basically on the left-hand side here, this shows you all the different items that are used across that InterRAI assessment, the home care assessment, to help to create a decision tree that can help us predict greater ED use in 6 months. And so when Dr. Costa helped develop this tool, he looked at all these home care clients in Winnipeg and also in Ontario. He looked at, through using ISIS data, how they were actually, what the pattern of ED utilization was. And then he was able to go back through and develop a decision tree using the InterRAI home care assessment data to help show what actually predicts from a level of 1 to 6 a person's future risk of going to an emergency department. So you can see how that decision tree is created. And if you go to the next slide, you can see a little bit more about the algorithm in a little bit more detail here. And again, if you get a score of 1, for example, then it says that you're at the lowest risk of this home care cohort for future emergency department use. But if you're a level 6, you're at highest risk. And again, this is based on things like seeing previous or recent use of an ED or hospital, and a person having cardiorespiratory symptoms. This puts the person at the highest risk, for example, versus things that you see towards the bottom that put people at the lowest risk as well. So this just gives you another sense of another output that comes out of an InterRAI assessment, a home care assessment. We'll go to the next slide. So I wanted to finish off by talking a little bit about InterRAI. I just wanted to show this slide here that shows you that with the outcomes here, when you actually look at that InterRAI assessment, that home care assessment in a person's through Connecting Ontario, you'll actually see at the very end of the InterRAI assessment is this page called Outcomes, and this is, I just highlighted the things that we've just talked about, and so you can see how what you have here are the final scores. Remember, the higher the score, the worse the outcome, for example. And it also kind of gives you a little bit of information here so that you can help to quickly understand what some of those outputs were. And then even go back to some of those sections to get a little bit more of that. We'll go to the next slide. So I talked again about the second generation assessments, and I just want to spend a few moments talking about clinical assessment protocols before we end, because this is another thing that comes out of an InterRAI assessment tool. So we'll go to the next slide. And what we see here is that CAPs are basically use InterRAI coded items to create reliable, person-centered assessment areas that support comprehensive care and service planning. So they can, for example, these clinical assessment protocols can highlight possible areas for referral to specialized services. They can also be used to identify people who might benefit from further assessments of specific problems because there's a risk of decline is higher than expected. There's a potential to improve, has actually increased, or their symptoms could be alleviated if the problem were addressed. And there are four broad areas of clinical assessment protocols that InterRAI home care assessments come up with. One are areas of CAPs in the area of functional performance. Another area is cognitive and mental health, social life, and clinical issues. We'll go to the next slide to understand this a bit more. So if you actually think about CAPs and how they're triggered, CAPs are triggered, again, we'll just go back one slide, thank you. So CAPs are triggered by research-based algorithms embedded in the assessment. So again, each one of these is linked to an international best practice standards. And some of the CAPs are triggered based on being present or not, or also triggered to facilitate the improvement or prevent decline. So for example, when you want to, like in terms of addressing a CAP, really what InterRAI teaches its assessors to do is basically say that if a CAP is triggered, you want to review what was actually triggered for that individual. And sometimes it's triggered by a yes, no, or that there's been a change or an opportunity noted. Then you determine if the triggered CAP is clinically important for the person now. And then you also want to prioritize the triggered CAP as part of developing a targeted care plan. So we'll go to the next slide now. So when you look at how this looks, if you again look at this individual's home care assessment, you'll see that there's a section 5, that shows you a summary of their client assessment protocol. And I just want to focus on this one domain here around functional performance. So this patient, for example, triggered one of the issues, which was that risk of institutional risk. So they triggered that. And you can see here what the care coordinator did was they identified, so they've acknowledged the CAP. They said, I see that that CAP has been triggered. And they said this will be addressed in the service plan. And that's what they've indicated. So really, but you can actually see that if a CAP has been triggered, really what this does is it gives the care coordinator a number of different options to say how they're actually acknowledging this issue and what are they doing. And again, it also says that, is this a false positive? Is this something that I've offered the client something, but they've actually declined the intervention, for example? Or they might say, oh, we've previously addressed this and this keeps coming up all the time, but it's been previously addressed, or this is a new issue and I'm actively going to address it and I'm going to indicate it in the service plan. So that's an understanding of how care coordinators are working with the client assessment protocols as well that are derived. We'll go to the next slide. So this just gives you a little bit of a window on what CAPs kind of look like, if you will. This is just a very, very high level summary, but really, basically whenever a CAP is triggered, for example, such as the institutional risk CAP, which is the bottom one here, for example, this really just is a very short little summary of what this CAP is about and what might trigger it. So the purpose of this CAP is to avoid premature admission to a long-term care home, and it identifies people with impaired functioning who are high risk of institutional risk, for example. And so this is where This is where, for example, if a person is scoring some of those scales and those are coming up high, that they have impaired function, that they're at high institutional risk, for example, this is where this will actually trigger that cap, for example. And if you actually look in the manual or the care planning instruments that are available to our LHIN coordinators or other people using InterRAI assessments, this is where statements will actually be generated, evidence-based statements that really help someone think about things they might want to incorporate in their care plan as well. So the one above, the home environment optimization, for example, you might identify through the environmental questions that there's issues with lighting, flooring, bathroom, toilet, kitchen, heating, repair, other things like this. And so because this has been triggered, for example, one of the suggestions, one of the clinical assessment protocols that would be presented to the care coordinator would be, you might want to consider an OT home safety assessment, for example. So that gives you a sense of a statement that would come out that we know is evidence informed, and then they might choose whether to do that or not. And back to that previous slide that we mentioned, this is where the care coordinator might say, I've offered the OT home safety assessment 28 times. The client keeps saying no. So yes, this keeps triggering all the time because this is an issue that's still here, but at least I'm aware of it. I've tried to address it, and or if it's the first time it's triggering, this is where they might say, I'm going to actually make a referral, and this will be reflected in the final plan that they put together. We'll go to the next slide here. So again, when you actually look at the final sections in this, make sure you take a look at the medication and section notes at the very end, because again, around each of the ones you might see, some people always, when they just simply look at an InterRAI assessment, they say, well, there might be some other contextual things that would be really helpful to understand the scoring that I'm providing. So for example, for the client that we've been working with here, you'll see some of the actual the extra notes that the care coordinator has written to help round out what they've scored in that section on cognition or the communication and vision that basically indicated that this client has a moderate of cognitive impairment. But they also gave some other context here, which is really helpful as well. So it's really good to look in on these things because it helps to give you a sense or contextualize a little bit of what the care coordinator is also seeing from that perspective. We'll just press the next button forward. And again, the assessments always as well list the LHIN care coordinator who is involved. So I love it because when I'm looking at a LHIN, a home care assessment, I'll always see the name of the LHIN coordinator who recently completed the assessment. And then I can get on the handy dandy one-mail system. I can find their email address and they can follow up with other questions as well. And a number of LHIN care coordinators are more than happy to chat back and forth saying, oh my goodness, thank you for reading my assessment. I didn't know anybody read them besides me. And this is where, again, you can facilitate a dialogue, or if you're in hospital, you can quickly be able to interact with someone who probably knows this client incredibly well. And you can see, for example, under the mood and behavior section, I know this care coordinator incredibly well. She said, and she says here, client is on quetiapine daily, has PRN dosage if needed, followed by a geriatrician in MSH. So she's got that knowledge and showing that because, for example, I see my colleague and friend Heather McLeod from Hamilton, for example, and she might say, geriatrician at MSH. Well, she might email me, or she might email that care coordinator and say, who's the geriatrician at MSH? And that might be helpful if my notes weren't in the system. So again, this is a way that, especially in geriatrics, where we're always trying to look for collateral, we can look at that. We'll just go to the next slide. So the conclusions really are that standardized clinical assessments like the InterRAI contact assessment can allow clinicians to speak a common language in the delivery of geriatric care. The InterRAI contact assessments and home care assessments are now readily accessible by all clinicians in Ontario through the Connecting Ontario patient information portal. Taking some time to familiarize yourself and learn how to navigate this viewing of the InterRAI contact assessment and home care forms can allow you to better appreciate the content within. And InterRAI assessments that are conducted routinely on intake and are for routine reassessments can help provide some valuable insights in terms of how an individual is previously functioning in the community and further opportunities for improvement, especially when it may be hard to otherwise get some good collateral information. And it can help really inform clinical decision making that much sooner. And I think that's it. I think that's my last slide. We just press forward. I think I have a thank you to everybody who's been listening. So we'll start.
Wonderful. And thank you to you, Dr. Sinha. Before we get to questions, we've only got a couple of minutes for questions, and we'll try to get to as many as we can. But in case we don't, can you recommend where people can get more information? Is there any other resources they can look at?
Absolutely, Wendy. So one of the things that my colleagues in New Zealand who have just launched a similar Connecting Ontario system in the country, they actually made a handy dandy manual for New Zealand clinicians of how to look at InterRAI assessments. So what I've done is I've taken out the New Zealand Connecting Ontario stuff. I've abridged that into a bit of a manual that I use to help me prepare this presentation. And our friends at the RGP have indicated they're going to be able to put that PDF document up on the website so people can look at that and be able to learn a little bit more. And then and that might be a next useful resource. You can also go to the InterRAI website where you can learn a little bit more about these individual scales as well.
Perfect. Thank you for sharing that information. So there's one important question here. I mean, all of them are important, but this one, would you consider the InterRAI the same as a comprehensive geriatric assessment?
Yeah, I saw that question, and really the InterRAI home care assessment is basically designed to be almost the equivalent of a CGA, right? So the key things to think about, again, it's asking a lot of the things that, say, a geriatrician would genuinely be interested in, a lot of those different domains. It helps generate scales and things, but ultimately, in the end, as specialized geriatric service providers or geriatricians, we're often used to taking what we see in the MMSE, the context, other things, and then helping us do that. So this doesn't replace the work of a geriatrician, but it can greatly facilitate, because when they've done a number of studies on this where I might just show a person an InterRAI contact assessment or this home care assessment. I've never seen the patient, and the care planning that I would come up with as a geriatrician is the same as another geriatrician would have, or I would have, if I had actually seen that patient. And InterRAI has done a number of those studies too, showing that the value of this can really speed up the work of a geriatrician when these forms are completed and shared.
Okay. There were two questions about the InterRAI, doing a follow-up InterRAI assessment, being able to measure, demonstrate improvement after patients receive services. Is that possible?
Absolutely. So the protocols that the LHINs do right now is for any client who's every 6 months or so, and if you're a client in long-term care, the InterRAI standard in Ontario and around the world is that we often recommend that there be a reassessment done every 6 months, or if there's a change in status. So if the individual, like that client that we were talking about in this one, they had actually recently come out of hospital, and so that would trigger a reassessment to be done by the LHIN care coordinator, if you will. So reassessments are routinely done every 6 months or during a change in status. And certainly sometimes, one might actually coordinate with the LHIN coordinator to encourage for a reassessment to be done when we might know of a change in status that they may not well. But the reason why that's important is, number one, as the status of the client changes, their scores will change, their scales will change, their caps will change, just like any patient's issues will change, and our responses need to evolve with them. That's why it's important to kind of reassess in our usual practice, and that's the value of this. The nice thing about InterRAI assessments is that once it's been collected, a lot of that information, especially in countries like Belgium or others, or New Zealand, where things are highly automated and more integrated, is it allows that information that was previously collected to repopulate a future assessment. And so that all the assessor has to do is only score things that have changed. And then that way it allows future reassessments to be done in much shorter periods of time as well, by giving them more quick access to the updated outcomes and clinical assessment protocols.
Great. So we need to wrap up now, and we want to say thank you very much for this great learning opportunity. And thank you to all those who attended as well. I know there were more questions, but there's great resources that will be shared with you after this webinar. Please take time to fill out our short evaluation survey that will come to you by email. We value your feedback. Also, just wanted to highlight that we've got new moves resources, a refreshed website. So there may be great information and pieces here you can use for your fall prevention strategies this November. And we wanted to also highlight our next webinar, which will be Sunnybrook in Chairs for Meals, Mobilization Intervention, which will be presented by Sunnybrook occupational therapists Kellen Baldock and Jonathan Lowe. And that will be on January 24th. Registration information for the webinar will be emailed to you soon. Thanks again, everyone, and we'll see you next time. We're signing off now.